Question 1. General medicine. Management of diabetes complications. 54-year-old male with 15-year history of type 2 diabetes mellitus presents to the clinic with complaints of intermittent blurry vision, tingling sensations in his feet, and fatigue. His fasting blood glucose is 178 mgl and HbA is 9.2%. On physical examination, there is decreased sensation in the bilateral feet and diminished ankle reflexes. What is the most appropriate next step in his management? A. Prescribe insulin therapy and recommend lifestyle changes. B. Start gabapentin for neuropathy and refer to ophthalmology for retinal screening. C. Increase the dose of his oral anti-diabetic medication and recheck HbA in 3 months. D. Refer for bariatric surgery as the first-line intervention. Answer. B. Start gabapentin for neuropathy and refer to ophthalmology for retinal screening. Explanation. This patient exhibits complications of poorly controlled diabetes, including diabetic neuropathy and retinopathy. The correct approach involves managing these complications alongside optimizing glucose control. Gabapentin is often prescribed for neuropathic pain, which is a common symptom of diabetic neuropathy. Ophthalmology is critical for retinal screening, as blurry vision suggests diabetic retinopathy. Incorrect answers. A. Insulin therapy may be considered, but addressing complications is immediately necessary. C. Adjusting antidiabetic medication alone overlooks complications. D. Bariatric surgery is not a first-line intervention for all patients. Relevant guidelines. American Diabetes Association (ADA) guidelines recommend comprehensive management of complications in patients with diabetes, including annual retinal screening and neuropathy assessment. Question 2. Emergency medicine. Toxicology and poisoning scenario-based. Mr. Harrison, 45-year-old male, is brought to the emergency department after ingesting an unknown quantity of acetaminophen 8 hours ago. He reports nausea, abdominal pain, and dizziness. On examination, he appears uncomfortable but is hemodynamically stable. Laboratory findings include elevated Aston alt, and his serum acetaminophen level is 250 mmol. What is the most appropriate treatment at this time? A. Administer activated charcoal. B. Provide supportive care and monitor liver function. C. Administer N-acetylcysteine, NAC intravenously. D. Perform immediate gastric lavage. Answer. C. Administer N-acetylcysteine, NAC intravenously. Explanation. This patient exhibits signs of acetaminophen overdose with a toxic serum level and liver injury markers. N-acetylcysteine, NAC, is the antidote for acetaminophen toxicity as it replenishes glutathione reserves and protects the liver from further damage. Incorrect answers. A. Activated charcoal is effective if administered within 1-2 hours post-ingestion. B. Monitoring alone risks worsening liver damage without addressing toxicity. D. Gastric lavage is not effective after 8 hours. Relevant guidelines. The RUMAC-Matthew nomogram is used to NAC administration based on serum acetaminophen levels and time since ingestion. Early intervention reduces the risk of fulminant hepatic failure. Question 3. Obstetrics and gynecology. Complications of pregnancy. 30-year-old female at 32 weeks of gestation presents to the clinic with severe headache, visual disturbances, and swelling in her hands and feet. Her blood pressure is 160/100 Thg and urinalysis reveals 3-proteinuria. What is the most appropriate next step in her management? A. Initiate Labocelol therapy and plan for delivery at 37 weeks. B. Admit to the hospital and administer magnesium sulfate. C. Perform an immediate cesarean section. D. Reassess in 24 hours with repeated blood pressure measurements. Answer. B. Admit to the hospital and administer magnesium sulfate. Explanation. The patient demonstrates severe preeclampsia characterized by hypertension, proteinuria, and end-organ involvement, headache, visual symptoms. Immediate management includes hospitalization to monitor maternal and fetal health, magnesium sulfate to prevent eclampsia, seizures. Delivery is the definitive treatment, but timing depends on gestational age. Maternal fetal stability. Incorrect answers. A. Antihypertensive therapy alone is insufficient for severe preeclampsia. C. Cesarean section is indicated only if maternal fetal conditions worsen. D. Delay in treatment risks eclampsia and other complications. Relevant guidelines. The American College of Obstetricians and Gynecologists (ACOG) guidelines emphasize magnesium sulfate and antihypertensives for severe preeclampsia with delivery based on maternal and fetal status. Question 4. A 65-year-old patient with a history of chronic obstructive pulmonary disease COPD presents to the emergency department with worsening shortness of breath, increased sputum production, and low-grade fever. On physical examination, the patient is tachypneic, using accessory muscles to breathe, and has wheezing on auscultation. A chest X-ray shows no evidence of pneumonia. What is the most appropriate next step in management? A. Begin intravenous antibiotics targeting gram-negative organisms. B. Administer inhaled short-acting beta agonists and initiate oral corticosteroids. C. Start non-invasive positive pressure ventilation (NIV) immediately. D. Administer intravenous magnesium sulfate to reduce bronchospasm. Answer: B. Administer inhaled short-acting beta agonists and initiate oral corticosteroids. Explanation: this patient is experiencing an acute exacerbation of COPD, as indicated by worsening dyspnea, increased sputum, and wheezing. The most appropriate next step includes inhaled short-acting beta agonists, SUBAs. These help relieve bronchospasm. Oral corticosteroids reduce airway inflammation and shorten recovery time. Option A. Antibiotics are only recommended if there are signs of a bacterial infection, e.g., fever, purulent sputum, or consolidation on imaging. The absence of pneumonia here does not support this approach. Option C. NIP is reserved for patients with severe respiratory acidosis, e.g., pH 7.35 or hypoxemia refractory to supplemental oxygen. Option D. Magnesium sulfate is typically used in severe asthma exacerbations, not COPD exacerbations. Relevant guidelines: Gold Global Initiative for Chronic Obstructive Lung Disease recommends SUBAs and corticosteroids as first-line treatments for acute exacerbations without significant respiratory distress or infection. Question 5. Mr. Patel, a 50-year-old man with poorly controlled diabetes mellitus, presents with a non-healing ulcer on the plantar aspect of his right foot. He reports no recent fevers or chills. Examination reveals a 3 cm ulcer with a purulent discharge and surrounding erythema, but no fluctuance or crepitus. The dorsalis pedis pulse is palpable and capillary refill is normal. Which of the following is the most appropriate step in his management? A. Perform bedside incision and drainage. B. Prescribe a 7-day course of oral antibiotics and reassess in 1 week. C. Order MRI of the foot to evaluate for osteomyelitis. D. Refer for immediate surgical debridement in the operating room. Answer: C. Order MRI of the foot to evaluate for osteomyelitis. Explanation: this patient presents with signs of a diabetic foot ulcer complicated by possible deep tissue involvement. Osteomyelitis should be suspected in chronic or non-healing ulcers, especially with purulent discharge. MRI is the most sensitive imaging modality to assess for osteomyelitis and determine the extent of soft tissue and bone involvement. Option A. There is no indication of abscess or fluctuance to warrant incision and drainage. Option B. While antibiotics are part of management, imaging is required to rule out osteomyelitis before definitive treatment. Option D. Immediate surgical intervention is not indicated unless there is evidence of necrotizing infection or gangrene. Relevant guidelines: the Infectious Diseases Society of America (IDSA) recommends MRI for suspected osteomyelitis in diabetic foot ulcers with clinical signs of deep infection. Question 6. A 25-year-old woman presents to the clinic with severe fatigue, generalized weakness, and weight loss over the past 3 months. She also reports frequent episodes of abdominal pain, nausea, and salt cravings. On examination, her blood pressure is 90/6 mmHg while seated and drops to 75/50 mmHg on standing. Initial labs reveal sodium of 128 mecl, potassium of 5.9 mecl, and glucose of 65 mdl. Which of the following is the most likely diagnosis? A. Hypothyroidism. B. Primary adrenal insufficiency. C. Syndrome of inappropriate antidiuretic hormone secretion, SIAD. D. Chronic kidney disease. Answer: B. Primary adrenal insufficiency. Explanation: this patient presents with classic features of primary adrenal insufficiency, Addison's disease, hyponatremia, and hypokalemia due to aldosterone deficiency. Orthostatic hypotension reflects low cortisol levels causing reduced vascular tone, hypoglycemia due to impaired gluconeogenesis. Salt cravings, a hallmark symptom of aldosterone deficiency. Option A. Hypothyroidism may cause fatigue and weight gain, but does not typically result in hyperkalemia or salt cravings. Option C. Side causes hyponatremia, but is not associated with hyperkalemia or hypotension. Option D. Chronic kidney disease might cause hyperkalemia, but other features like hypoglycemia and salt cravings are not typical. Relevant guidelines. The Endocrine Society recommends ACT stimulation testing and serum cortisol levels to confirm primary adrenal insufficiency in suspected cases. Question 7. A 34-year-old man presents to the clinic with a 2-week history of right knee pain and swelling following a soccer match. He denies fever or recent trauma. On examination, the knee is swollen with a small effusion and limited range of motion, but no erythema or warmth. Initial X-rays show no fractures or dislocations. What is the most appropriate next step in the management of this patient? A. Prescribe oral NSAIDs and recommend rest. B. Perform arthrocentesis and analyze the synovial fluid. C. Order an MRI to assess for ligament or meniscal injury. D. Refer to an orthopedic surgeon for surgical evaluation. Answer. B. Perform arthrocentesis and analyze the synovial fluid. Explanation. The presence of knee pain, swelling, and effusion raises concern for conditions like infection, gout, or inflammatory arthritis. Arthrocentesis provides critical diagnostic information through synovial fluid analysis, helping differentiate between septic arthritis, gout, and other inflammatory causes. Option A. NSAIDs may alleviate symptoms, but without a diagnosis, this approach is insufficient. Option C. MRI useful for assessing structural injuries, but is not the first step in this scenario with effusion and no trauma history. Option D. Orthopedic referral is premature without a clear diagnosis. Of relevant guidelines, the American College of Rheumatology recommends synovial fluid analysis for unexplained joint effusions to guide diagnosis and management. Question 8. A 55-year-old woman with a history of poorly controlled hypertension presents with sudden onset severe headache, vomiting, and confusion. Her blood pressure is 220/100 Hg on arrival. Neurological examination reveals left-sided hemoptysis. What is the most likely diagnosis? A. Ischemic stroke. B. Subarachnoid hemorrhage. C. Intracerebral hemorrhage. D. Hypertensive encephalopathy. Answer. C. Intracerebral hemorrhage. Explanation. This patient presents with sudden onset severe headache, vomiting, and focal neurological deficits, which are hallmark signs of intracerebral hemorrhage. The extremely high blood pressure and history of uncontrolled hypertension strongly suggest hypertensive damage to cerebral vessels, leading to rupture and bleeding. Option A. Ischemic strokes are less commonly associated with severe headache and vomiting and more commonly present with focal deficits alone. Option B. Subarachnoid hemorrhage typically causes a thunderclap headache without focal neurological deficits. Option D. Hypertensive encephalopathy can cause confusion and headache but does not cause focal neurological deficits. Relevant guidelines. The American Heart Association emphasizes imaging with a non-contrast CT scan to confirm it and determine the extent of bleeding. Question 9. A 42-year-old woman presents with persistent heartburn and regurgitation for the past 6 months. She reports symptoms occurring mainly after meals and when lying down. Lifestyle modifications, including avoiding late-night meals, have provided minimal relief. She denies dysphagia or weight loss. What is the most appropriate next step in management? A. Start a trial of proton pump inhibitors, PPIs. B. Perform an upper endoscopy to rule out malignancy. C. Refer for 24-hour pH monitoring. D. Prescribe H receptor antagonists. Answer A. Start a trial of proton pump inhibitors, PPIs. Explanation. The patient's symptoms are consistent with gastroesophageal reflux disease GERD. PPIs are the first-line treatment for persistent GERD symptoms as they effectively suppress gastric acid production. Option B. Upper endoscopy is reserved for alarm symptoms e.g. dysphagia, weight loss, bleeding, or refractory cases. Option C. pH monitoring is used for diagnostic uncertainty or when surgical intervention is being considered. Option D. H receptor antagonists are less effective than PPIs for moderate to severe GERD. Relevant guidelines. The American College of Gastroenterology recommends an initial trial of PPIs for patients with classic GERD symptoms without alarm features. Question 10. A 28-year-old woman presents with a fever of 39 102.2, sore throat, and fatigue for the past week. Examination reveals cervical lymphadenopathy, tonsillar exudates, and mild hepatosplenomegaly. Rapid strep test is negative. What is the most appropriate next step? A. Perform monospot test for infectious mononucleosis. B. Begin empiric antibiotics for bacterial pharyngitis. C. Prescribe corticosteroids to reduce inflammation. D. Order throat culture to confirm group streptococcus. Answer A. Perform a monospot test for infectious mononucleosis. Explanation: the patient's presentation of fever, pharyngitis, cervical lymphadenopathy, and hepatosplenomegaly is classic for infectious mononucleosis caused by Epstein-Barr virus. The monospot test is a quick and reliable diagnostic tool in this context. Option B. Antibiotics are unnecessary for viral infections and can lead to rash and mononucleosis. Option C. Corticosteroids are only indicated in severe cases. G. Airway obstruction. Option D. Throat culture is not necessary given the negative, rapid strep test and the clinical picture suggesting mononucleosis. Relevant guidelines. Infectious Diseases Society of America recommends monospot testing or Epstein-Barr virus-specific antibody testing for suspected mononucleosis. Question 11. A 60-year-old man presents with chest pain that started 2 hours ago. The pain is described as crushing, located retrosternally, and radiates to the left arm. He is diaphoretic and nauseated. On examination, his blood pressure is 145/9 mmHg, heart rate is 110 bpm, and he has no murmurs. What is the most appropriate initial diagnostic test? A. Chest X-ray. B. Serum troponin levels. C. 12-lead electrocardiogram. D. Echocardiogram. Answer C. 12-lead electrocardiogram. Explanation: in a patient with acute chest pain suggestive of myocardial infarction, a 12-lead ECG is the first diagnostic test to identify segment changes or arrhythmias. This is essential for diagnosing STEMI or NSTEMI and guiding immediate treatment. Option A. Chest X-ray is not the first-line test for acute chest pain and is mainly used to rule out other causes like aortic dissection or pneumothorax. Option B. Serum troponin levels are crucial for confirming myocardial injury, but take time and do not provide immediate diagnostic information. Option D. Echocardiogram can assess wall motion abnormalities, but is not the initial diagnostic test in acute chest pain. Relevant guidelines. The American Heart Association recommends a 12-lead ECG within 10 minutes of presentation for patients with suspected acute coronary syndrome. Question 12. A 35-year-old woman presents with fatigue, pallor, and frequent headaches for the past 2 months. Laboratory tests reveal hemoglobin of 8 grams per mean corpuscular volume (MCV) of 70 FL and ferritin of 5 ng/ml. What is the most likely cause of her symptoms? A. Vitamin B deficiency. B. Iron deficiency anemia. C. Thalassemia trait. D. Anemia of chronic disease. Answer B. Iron deficiency anemia. Explanation: the patient's microcytic anemia, low MCV, and low ferritin are consistent with iron deficiency anemia, which is the most common cause of anemia worldwide. Symptoms such as fatigue and pallor are typical. Option A. Vitamin B deficiency causes macrocytic anemia with elevated MCV. Option C. Thalassemia trait may cause microcytic anemia, but typically has normal or elevated ferritin levels. Option D. Anemia of chronic disease typically presents with low serum iron at normal or elevated ferritin levels. Relevant guidelines. The World Health Organization recommends evaluating ferritin levels to confirm iron deficiency anemia and identify underlying causes. Question 13. A 45-year-old man with a history of alcohol use disorder presents with confusion, ataxia, and nystagmus. On examination, he is disoriented and unable to stand steadily. What is the most appropriate initial treatment? A. Intravenous thiamine. B. Oral folic acid. C. Intravenous glucose. D. Intravenous benzodiazepines. Answer A. Intravenous thiamine. Explanation: the patient's symptoms are consistent with Wernicke encephalopathy, complication of thiamine deficiency commonly seen in alcohol use disorder. Intravenous thiamine should be administered immediately to prevent progression to Korsakoff syndrome. Option B. Folic acid supplementation is important in alcohol use disorder but does not treat Wernicke encephalopathy. Option C. Administering glucose without prior thiamine can worsen symptoms by depleting thiamine further. Option D. Benzodiazepines are used for alcohol withdrawal but do not address thiamine deficiency. Relevant guidelines. The European Society for Clinical Nutrition and Metabolism recommends thiamine supplementation before glucose administration in patients at risk of Wernicke encephalopathy. Question 14. A 25-year-old woman presents with acute onset right lower abdominal pain and nausea. Her last menstrual period was 6 weeks ago. A urine pregnancy test is positive. What is the most appropriate next step in management? A. Perform an abdominal ultrasound. B. Prescribe analgesics and observe. C. Order a serum beta-HCG level. D. Refer for emergent laparoscopy. Answer A. Perform an abdominal ultrasound. Explanation. The clinical presentation of abdominal pain, delayed menses, and a positive pregnancy test raises concern for an ectopic pregnancy, which is a life-threatening condition. A transvaginal or abdominal ultrasound is the first diagnostic step to confirm the location of the pregnancy. Option B. Observation without diagnosis is inappropriate due to the risk of rupture. Option C. beta-HCG levels can be supportive but are not diagnostic without imaging. Option D. Laparoscopy is reserved for confirmed or suspected ruptured ectopic pregnancy. Relevant guidelines. The American College of Obstetricians and Gynecologists recommends immediate ultrasound in cases of suspected ectopic pregnancy. Question 15. A 50-year-old man with a 30-pack-year smoking history presents with a chronic cough, hemoptysis, and unintentional weight loss. Chest X-ray reveals a 3 cm mass in the right upper lobe. What is the most appropriate next step? A. Start empiric antibiotics for presumed pneumonia. B. Refer for a C. Guided biopsy of the lung mass. C. Schedule pulmonary function testing. D. Order a sputum cytology test. Answer B. Refer for a C-guided biopsy of the lung mass. Explanation. The patient's symptoms and imaging findings raise suspicion for lung cancer. CT-guided biopsy is the most appropriate step to establish definitive diagnosis. Option A. Antibiotics are not indicated as this is unlikely an infectious process. Option C. Pulmonary function testing may be done later to assess surgical risk but is not the first step. Option D. Sputum cytology has limited sensitivity compared to biopsy. Relevant guidelines. The American Cancer Society emphasizes tissue diagnosis via biopsy for definitive lung cancer diagnosis and staging. Question 16. A 65-year-old man presents with sudden onset left-sided weakness and slurred speech for the past 2 hours. His blood pressure is 100/100 mmHg, and a non-contrast CT of the head shows no intracranial hemorrhage. What is the most appropriate next step in management? A. Administer aspirin immediately. B. Lower blood pressure aggressively to 104/9 mmHg. C. Administer intravenous alteplase TPA. D. Perform emergent carotid endarterectomy. Answer C. Administer intravenous alteplase TPA. Explanation. The presentation suggests an acute ischemic stroke, and the absence of hemorrhage on the CT scan makes the patient eligible for thrombolytic therapy. Intravenous alteplase is the treatment of choice if initiated within 4.5 hours of symptom onset. Option A. Aspirin is used in stroke prevention but is not appropriate before thrombolytic therapy. Option B. Aggressive blood pressure lowering is not recommended during the acute phase of ischemic stroke unless 185/100 THg in thrombolysis candidates. Option D. Carotid endarterectomy is indicated for significant carotid stenosis but not in the acute phase. Relevant guidelines. The American Heart Association recommends thrombolysis for eligible patients with acute ischemic stroke presenting within 4.5 hours. Question 17. A 45-year-old woman presents with a painless lump in her right breast that she noticed 2 weeks ago. On examination, there is a firm, non-tender mass in the upper outer quadrant of the right breast. An axillary lymphadenopathy is noted. What is the most appropriate next step? A. Schedule a follow-up exam in 6 weeks. B. Order a mammogram and ultrasound of the breast. C. Prescribe antibiotics for presumed mastitis. D. Perform fine needle aspiration. Answer B. Order mammogram and ultrasound of the breast. Explanation. The presentation is concerning for breast cancer, and imaging is the next step in the diagnostic workup. Mammography and ultrasound help characterize the mass and guide further interventions like biopsy. Option A. Delaying evaluation is inappropriate given the findings. Option C. Antibiotics are not indicated without signs of infection. Option D. Biopsy is necessary but typically follows imaging. Relevant guidelines. The American Cancer Society recommends prompt imaging and biopsy for any new palpable breast mass in patients over 40. Question 18. A 70-year-old man with a history of hypertension and diabetes presents with lower abdominal pain, inability to urinate, and suprapubic fullness. What is the most appropriate initial management? A. Administer alpha blockers. B. Perform a digital rectal exam. C. Insert a urinary catheter. D. Order a renal ultrasound. Answer: C. Insert a urinary catheter. Explanation: the patient's symptoms and examination findings suggest acute urinary retention, which requires immediate bladder decompression with urinary catheter. Option A. Alpha blockers may help in benign prostatic hyperplasia but are not the first step in acute retention. Option B. Digital rectal exam may provide additional information but does not address the acute problem. Option D. Renal ultrasound is useful for detecting hydronephrosis but is not the first-line intervention. Relevant guidelines. Urological guidelines recommend catheterization as the initial management for acute urinary retention. Question 19. A 55-year-old woman with chronic kidney disease presents with generalized fatigue, bone pain, and pruritus. Laboratory tests reveal calcium of 7.5 mdl, phosphate of 6.5 mdl, and parathyroid hormone pH levels significantly elevated. What is the most likely diagnosis? A. Primary hyperparathyroidism. B. Secondary hyperparathyroidism. C. Tertiary hyperparathyroidism. D. Vitamin D deficiency. Answer: B. Secondary hyperparathyroidism. Explanation: the patient's chronic kidney disease leads to secondary hyperparathyroidism due to reduced phosphate excretion, low calcium levels, and impaired vitamin D metabolism, causing pH elevation. Option A. Primary hyperparathyroidism causes hypercalcemia, not hypocalcemia. Option C. Tertiary hyperparathyroidism occurs after long-standing secondary hyperparathyroidism and is associated with autonomous BH secretion. Option D. Vitamin D deficiency alone would not account for the elevated phosphate levels. Relevant guidelines. The National Kidney Foundation recommends management of mineral bone disease in chronic kidney disease patients to control pH, calcium, and phosphate levels. Question 20. A 30-year-old woman presents with episodes of palpitations, sweating, and headaches. Blood pressure is 106 to 100 mmHg, and laboratory studies reveal elevated plasma methampherenes. What is the next best step in management? A. Administer a beta blocker immediately. B. Order a 24-hour urinary cortisol test. C. Perform an abdominal ET or MRI. D. Refer for adrenalectomy. Answer: C. Perform an abdominal ET or MRI. Explanation: the patient's symptoms and elevated plasma methampherenes are suggestive of pheochromocytoma, catecholamine-secreting adrenal tumor. Imaging with ET or MRI is necessary to localize the tumor before definitive management. Option A. Beta blockers alone can precipitate hypertensive crisis in pheochromocytoma. Alpha blockade should precede beta blockade. Option B. Cortisol testing is for suspected Cushing's syndrome, not pheochromocytoma. Option D. Adrenalectomy is the definitive treatment but requires preoperative stabilization and imaging confirmation. Relevant guidelines. The Endocrine Society recommends imaging studies to confirm tumor location after biochemical diagnosis of pheochromocytoma. Question 21. A 25-year-old man presents with the painful swollen knee after a soccer game. He recalls hearing a pop at the time of injury. On examination, there is significant swelling, limited range of motion, and a positive Latchman test. What is the most likely diagnosis? A. Meniscal tear. B. Anterior cruciate ligament ACL tear. C. Posterior cruciate ligament PCL tear. D. Patellar dislocation. Answer: B. Anterior cruciate ligament ACL tear. Explanation: the history of swelling and a positive Latchman test are classic findings of an ACL tear, a common sports injury. Option A. A meniscal tear typically causes joint line tenderness and locking but not an acute POP. Option C. A CR is less common and usually results from direct trauma to the anterior tibia. Option D. Patellar dislocation may cause pain and deformity, but the Latchman test is not positive. Relevant guidelines. MRI is the gold standard for confirming ACL tears. Early physical therapy and possible surgical intervention are recommended based on activity level. Question 22. A 45-year-old woman presents with a 6-month history of progressive fatigue, cold intolerance, and weight gain. On examination, her skin is dry and her reflexes are delayed. Laboratory tests reveal TSH of 12 mil normal, 0.4, 4.0, and 3 to below normal. What is the most likely diagnosis? A. Subclinical hypothyroidism. B. Primary hypothyroidism. C. Central hypothyroidism. D. Euthyroid 6 syndrome. Answer: B. Primary hypothyroidism. Explanation: the elevated TH and low FreeT indicate primary hypothyroidism, likely due to autoimmune thyroiditis Hashimoto's disease. Option A. Subclinical hypothyroidism has elevated TH but normal FreeT. Option C. Central hypothyroidism is caused by pituitary or hypothalamic dysfunction leading to OTSH and low FreeT. Option D. Euthyroid 6 syndrome occurs in critically ill patients with low and sometimes low but normal TSH. Relevant guidelines. The American Thyroid Association recommends levothyroxine therapy for overt hypothyroidism. Question 23. A 32-year-old woman presents with sudden onset severe right upper quadrant pain radiating to her back, nausea, and vomiting after a fatty meal. On examination, she has a positive Murphy sign. What is the most appropriate next diagnostic step? A. Abdominal CT scan. B. Endoscopic retrograde cholangiopancreatography. C. Abdominal ultrasound. D. Magnetic resonance cholangiopancreatography (LE). Answer: C. Abdominal ultrasound. Explanation: the presentation is consistent with acute cholecystitis, and abdominal ultrasound is the first-line imaging modality to confirm the diagnosis by detecting gallstones, thickened gallbladder wall, and pericholecystic fluid. Option A. CT scan is not as sensitive for gallstones. Option B. ERP is used for biliary obstruction but is not the initial diagnostic test. Option D. RCP is more advanced imaging for biliary tree evaluation but is not first line. Relevant guidelines. Early cholecystectomy is the definitive treatment for acute cholecystitis. Question 24. A 65-year-old man presents with chest discomfort and dyspnea while mowing the lawn. His symptoms resolve with rest. An egg shows normal sinus rhythm with no changes. What is the most likely diagnosis? A. Acute coronary syndromax. B. Stable angina. C. Unstable angina. D. Non-cardiac chest pain. Answer: B. Stable angina. Explanation: chest discomfort triggered by exertion and relieved by rest is characteristic of stable angina caused by myocardial ischemia due to fixed coronary artery stenosis. Option A. AX includes unstable angina and myocardial infarction, which typically present with more severe or prolonged symptoms. Option C. Unstable angina involves symptoms at rest or worsening in frequency and severity. Option D. Non-cardiac chest pain lacks typical anginal features. Relevant guidelines. Initial management includes nitrates, beta blockers, and lifestyle modification, with further evaluation by stress testing or coronary angiography. Question 25. A 55-year-old man with a 30-pack-year smoking history presents with hemoptysis, weight loss, and a persistent cough. A chest X-ray reveals a mass in the right upper lobe. What is the most appropriate next step in management? A. Start empiric antibiotics for pneumonia. B. Perform a C-guided biopsy. C. Order sputum cytology. D. Schedule a follow-up chest X-ray in 6 weeks. Answer: B. Perform a C-guided biopsy. Explanation: the clinical presentation and imaging findings are suspicious for lung cancer, and a tissue diagnosis via CT-guided biopsy is necessary to confirm malignancy. Option A. Antibiotics are not indicated for a mass suggestive of malignancy. Option C. Sputum cytology is less sensitive than biopsy for diagnosis. Option D. Delaying definitive evaluation is inappropriate. Relevant guidelines. Smoking cessation, imaging, and tissue biopsy are essential components of the workup for suspected lung cancer. Question 26. A 42-year-old woman presents with fatigue, generalized weakness, and intermittent palpitations. On examination, she has conjunctival pallor and a systolic flow murmur. Laboratory tests reveal a hemoglobin level of 8 grams per mean corpuscular volume (MCV) of 70 FL and low serum ferritin. What is the most likely underlying cause? A. Vitamin B deficiency. B. Chronic disease. C. Iron deficiency anemia. D. Thalassemia. Answer: C. Iron deficiency anemia. Explanation: the microcytic anemia, low MCV, and low ferritin iron stores strongly suggest iron deficiency anemia, often caused by blood loss or poor iron intake. Option A. Vitamin B deficiency causes macrocytic anemia high MCV. Option B. Anemia of chronic disease usually has normal or high ferritin levels. Option D. Thalassemia can cause microcytic anemia but typically has a normal ferritin level. Relevant guidelines investigating the source of blood loss, e.g. gastrointestinal bleeding, is essential along with iron supplementation for treatment. Question 27. A 50-year-old man presents with a sudden onset of severe left flank pain radiating to the groin, nausea, and hematuria. On examination, he appears restless and has costovertebral angle tenderness. What is the most appropriate next diagnostic step? A. Abdominal ultrasound. B. Non-contrast CT scan of the abdomen and pelvis. C. Intravenous pyelogram. If D. Plain abdominal X-ray. Answer: B. Non-contrast CT scan of the abdomen and pelvis. Explanation: the presentation is classic for renal colic due to a kidney stone, and a non-contrast CT scan is the most sensitive and specific imaging modality for detecting urinary calculi. Option A. Ultrasound is an alternative for patients who cannot undo CT, but is less sensitive for small stones. Option C. IPs are outdated and rarely used. Option D. Plain X-ray detects only radiopaque stones and has low sensitivity. Relevant guidelines. Initial management includes hydration, pain control, and alpha blockers to facilitate stone passage for small calculi. Question 20. A 65-year-old man with a history of hypertension and smoking presents with sudden onset tearing chest pain radiating to his back. His blood pressure is 109 to 100 Hg and his heart rate is 110 bpm. What is the most likely diagnosis? A. Acute myocardial infarction. B. Aortic dissection. C. Pulmonary embolism. D. Tension pneumothorax. Answer: B. Aortic dissection. Explanation: the classic presentation of aortic dissection includes tearing chest pain radiating to the back, hypertension, and possible asymmetry in pulses or blood pressure between limbs. Option A. Myocardial infarction pain is typically pressure-like and substernal. Option C. Pulmonary embolism causes pleurisy pain, tachycardia, and dyspnea. Option D. Tension pneumothorax presents with hypotension, respiratory distress, and absent breath sounds. Relevant guidelines: immediate imaging with CT angiography or transesophageal echocardiography (T) is recommended for diagnosis. Question 29. A 28-year-old woman presents with fever, chills, dysuria, and left flank pain. On examination, she has costovertebral angle tenderness. Urinalysis shows puria, bacteriuria, and white cell casts. What is the most likely diagnosis? A. Cystitis. B. Urethritis. C. Acute pyelonephritis. D. Glomerulonephritis. Answer: C. Acute pyelonephritis. Explanation: the systemic symptoms, fever, chills, and the presence of flank pain with puria and white cell casts indicate acute pyelonephritis, an infection of the kidney. Option A. Cystitis involves dysuria and frequency without systemic symptoms. Option B. Urethritis presents with dysuria but no flank pain or systemic symptoms. Option D. Glomerulonephritis causes hematuria and proteinuria but not puria or casts specific to infection. Relevant guidelines: empiric antibiotics such as fluoroquinolones or ceftriaxone are indicated until culture results are available. Question 30. A 34-year-old woman presents with progressive muscle weakness, difficulty climbing stairs, and rash over her eyelids. On examination, she has violaceous papules over her knuckles and proximal muscle weakness. What is the most likely diagnosis? A. Polymyositis. B. Dermatomyositis. C. Systemic lupus erythematosus. D. Rheumatoid arthritis. Answer: B. Dermatomyositis. Explanation: the combination of proximal muscle weakness and heliotrope rash on the eyelids, along with Gottron's papules on knuckles, is characteristic of dermatomyositis, an inflammatory myopathy with dermatologic manifestations. Option A. Polymyositis causes muscle weakness but lacks skin findings. Option C. SLE has a wide range of symptoms but does not typically cause proximal weakness and Gottron's papules. Option D. Rheumatoid arthritis primarily affects joints, not muscles. Relevant guidelines: diagnosis is supported by elevated muscle enzyme zinc and muscle biopsy. Treatment involves corticosteroids and immunosuppressive agents.